Good evening, everyone, and welcome to our annual Minnesota Nurses Peer Support Network continuing education event. My name is Sarah Cassell, and I am the co-chair of the board of directors, leading this work with my colleague, Carrie Capel, and a few other leaders in the community. First, I would like to take this opportunity to thank all of you for joining us virtually this evening for a very important and sensitive conversation. Our webinar topic this evening is it my problem? Why to care and what to do when concerned that a colleague has substance use disorder. So again, that's, is it my problem? Why to care and what to do when concerned that a colleague has substance use disorder. NPSN was founded in 2014 by Marie Manthe, who made a brave decision not to suffer in silence, but to speak up, not only for herself, but to advocate for other healthcare professionals who were going through similar lived experiences. Today, this nonprofit organization continues to widen its sphere of influence through dedicated volunteers that have put together this very powerful and informative program for all of you this evening. As a nurse leader with over 20 years of experience, I have witnessed the stigma on healthcare professionals with substance use disorder and the lack of resources and support that is sometimes, that they don't have when they're trying to navigate this healthcare system alone. So tonight, I'm hopeful that each of you will leave this webinar with more information and some more tools in your toolbox to support a colleague or a friend with substance use disorder. And now I'll pass it on to Dr. Dina Stewart, one of the presenters, to take it on from here. Thank you again for your time.
Thank you, Sarah. Again, we're part of the Nursing Peer Support Network. This is our web address and email. I would like to introduce the members of the Education Committee, Ashley Arbuckle, Barbara Forshear, Patty Kaiser, Carrie Capel, Deb Matthias Anderson, Karen Pop, Sarah Simons, and myself, Dina Stewart. So I'm Dina Stewart. I'm a psychiatric mental health nurse practitioner, and I've been on the Education Committee for Nursing Peer Support Network since 2018. Today, our objectives are to learn common signs and symptoms of possible substance use disorder in a colleague, explain the different actions a nurse can take to intervene when concerned, talk about the role of the Minnesota Health Professional Services Program, or HPSP, and go over reporting obligations in Minnesota, including the ethical and legal matters. Before we get too far, we're going to intersperse our presentation with little quizzes or polls to test your knowledge. The poll should show up on the Zoom. Your responses are anonymous. Okay, so test your knowledge number one. What might you see in a colleague who has a problem with substance use disorder? And you can check all that apply. Would you see drowsiness, wearing long sleeves in a warm environment, dyed hair, tattoos, dry skin, excessive sweating, self-isolation? Please go ahead and click what you think you might see. Let's see what the results are. Okay, so a lot of people thought drowsiness, wearing long sleeves, sweating, self-isolation, dyed hair, tattoos, dry skin. Okay, great. We're going to come back to the answers we're looking for at the end of my section. So we titled this presentation, Why Should I Care? And hopefully by the end, you'll know why and you'll feel more knowledgeable and empowered about this issue. It's estimated that the rate of substance use disorder among nurses is the same as the general public, which is about 10%. As of April 2023, there were about 130,000 nurses in Minnesota. So that means about 13,000 nurses have experienced substance use disorder at some time. The Nursing Peer Support Network was able to provide support to 500 nurses in August of 2023. And we're proud and excited we were able to reach those 500 nurses, but that's only 3% of the estimated 13,000 that may benefit from peer support. Substance use disorder in nursing is an under-recognized practice issue. On a personal level, untreated substance use disorder impacts the individual nurse's physical, emotional, and spiritual health. It affects the workplace, whether that nurse is working while impaired or in withdrawal or calling in sick. Substance use disorder often develops from maladaptive coping. Alcohol use especially often develops in nursing school. Just think about how stressful a time that was. Alcohol is socially acceptable, and there is not always a clear line when alcohol use slips into something that meets criteria for a disorder. Substance use disorder can be life-threatening due to the risk of overdose, but many people don't know that the risk for suicide increases substantially when a nurse with substance use disorder starts to have workplace consequences. There is a conspiracy of silence around substance use disorder in nursing. We're going to talk about stigma more later in the presentation, but the stigma often keeps everyone around a person who is in trouble from acknowledging and addressing it with them. Not talking about it only perpetuates the issue. The nurse doesn't get the help they need and moves from work setting to work setting, jeopardizing themselves, the patients under their care, and the reputation of capital N nursing. The attitude that substance use disorder is a moral failure also perpetuates the issue. Reframing substance use disorder, basing it as a chronic disease that has effective treatments, stops the cycle of the nurse moving from job to job and allows them to recover. This helps the nurse and helps the profession of nursing. It's a loss to the profession when jobs and licenses are lost due to untreated substance use disorder. Their careers are worth saving, and it's in the interest of the profession to help nurses succeed in recovery. So now that you know why you should care about substance use disorder in nursing, we'll talk about some additional tools. You need to know the risks that are unique to nurses for developing a substance use disorder. First, we have attitudes. As I said a moment ago, the attitude that substance use disorder is a moral failure rather than a chronic illness is pervasive. There are many other underlying attitudes of nurses that put them at greater risk for developing problematic substance use. Nurses see ourselves as not vulnerable to developing problems. We see medications as a solution to our issues. We also don't emphasize self-care enough, leading to maladaptive coping. Alcohol use, as I said before, is socially acceptable, and it's seen everywhere as a means to cope with stress. It's a lot less effort to have a few drinks trying to get rid of the negative thoughts or images out of your mind than it is to find a good therapist and figure out how you're going to fit in an hour every week to process the moral injuries of working in our current healthcare system. Next, we have access, and this includes access to drugs and medications themselves, as well as access to knowledge related to diseases in which opioids are regularly prescribed. Some nursing work sites provide nurses easier access to medications because they need to be given quickly. Critical care areas in the emergency department, for instance, which incidentally have higher rates of nurses with substance use disorder. Having the knowledge and ability to easily obtain substances is a factor that increases the risk for nurses. The lack of education risk factor relates to the omission of substantial content in nursing preparatory programs about the unique risks for nurses in developing substance use disorder, and the omission of the possible consequences nurses face when substance use disorder becomes an issue for them. This lack of education diminishes awareness of substance use disorder as an issue and also contributes to the perpetuation of stigma. And stress is the fourth risk factor. So many factors related to working as a nurse are stressful, not to mention stress if the nurse has a family or other obligations. Put stress together with the attitude risk factor I talked about earlier, with the absence of education about risks and consequences, and that is your recipe for nurses having the same rate of substance use disorder as the general public. In addition to knowing the risks for all nurses, you should know what signs may be present in colleagues who may be facing challenges. These signs may be most evident in noticing changes over time. So first we have behavioral signs, attendance issues, people not showing up for their shifts, frequent breaks, or disappearing for longer than usual times, self-isolation, avoiding being around colleagues, irritability. Physical signs include changes in appearance, less attention to self-care, reddened eyes, odors of alcohol, hyperactivity, and this would be above just being caffeinated, wearing long sleeves in a warm environment, excessive sweating, clumsiness. And signs of diversion include when colleagues volunteer all the time to administer medications, especially controlled meds, might volunteer to work overtime or extra shifts. If people's patients complain that their pain relief is not effective, and if there's discrepancies in medication counts or high amounts of opioid wastes. Okay, so let's get back to the first test your knowledge. What might you see in a colleague who has a problem with substance use disorder? So most of the people responded with these answers, which would be drowsiness, wearing long sleeves in a warm environment, excessive sweating or self-isolation. Dry hair, tattoos, dyed hair, tattoos, and dry skin are not associated with signs of substance use disorder. In order to bring home the reality of substance use disorder for nurses, I would like to introduce a nurse in recovery who is sharing her story with us today. Carrie Capel is in long-term recovery, and she also happens to be co-chair of the board for the Nursing Peer Support Network. We'll be weaving Carrie's story throughout our presentation today. Welcome, Carrie.
Thanks, Dina. So the first thing I'm going to do is explain the purple hair. I don't know if all of you can see this, but my hair is a pretty vivid color of purple. This is the only part of my information that I'm actually kind of going to read to you. Starting about 3 weeks ago, just before the beginning of September, I did a fundraiser for Nurses Peer Support Network. And this was my first start out in announcing it on the GoFundMe, was have you ever wanted to do something that is a little bit, a lot bit out of your normal wheelhouse, to raise money for an organization or a cause that you believe in? For me, this is it, and I need your help to make a big difference. I'm raising money to benefit Nurses Peer Support Network, and while any donation will make an impact, I'm hoping you might consider doubling up the amount. My wish is to raise at least $5,000 in the next 3 weeks. In exchange for surpassing or even coming close to my goal by 9/8, I will have my entire head of hair dyed a bright purple, wearing it that way until it grows out in a few months. Why dye my hair a vivid color, you ask? Because most of my life I've made choices to fit in instead of stand out. And I'm taking the risk to ask for your help. This is how much I believe in the work that NPSN does in supporting nurses with mental health issues, specifically substance use disorder. Some may ask, why purple and why in September? The color purple was adopted as the color of recovery in 1989 for National Recovery Month. Recovery Month is a national observance held every September to educate Americans that substance use treatment and mental health services do enable those with mental health and or substance use disorder to live a healthy and rewarding life. In addition, September 9th, 2023 is the Walk for Recovery at the Minnesota State Capitol grounds. So my new hairdo can make a splash at the and debut at the walk. I am living proof that recovery works as a nurse in long-term sobriety for more than 14 years. A little bit more information about Nurses Peer Support Network that I provided was NPSN provides direct support for nurses by nurses recovering from substance use disorder. while educating about substance use disorder to nurses, nurse employers, organizations, and nurse educators. Minnesota is home to more than 130,000 licensed health nurses, and substance use disorder is a chronic disease that affects 1 in 10 in the general population, and perhaps more in nurses because of the high risk factors that are associated with our profession. Nurses Peer Support Network is run entirely by dedicated volunteers and one very part-time executive director who you'll meet tonight, which ensures the money that is donated to the organization goes to support the mission. Since 2020, the COVID pandemic has exacerbated nurses' mental fatigue, leaving even more nurses vulnerable to developing this disorder. And the money raised will help support outreach measures in Minnesota and to raise awareness about NPSN and educate the public, nurses, and organizations on the disease and the profession. It will also help address the stigma associated with substance use disorder in nurses. So please join me in the hair-raising fundraiser for Nurses Peer Support Network and donate now. And while we won't be promoting the GoFundMe at this CE event, we will supply our link to our website. So should you want to donate, we would also count those funds towards our hair-raising fundraiser as well to benefit the work that we do. So let me go on a little bit more about my story, and I'm going to tell it in 4 or 5 parts weaved throughout our time tonight. I have been a nurse since the late 1980s. I started out as an LPN and did some OCMED testing for major corporations around the United States. Originally grew up in the Twin Cities. I moved back to the Twin Cities after having this job and living out in California for a little while. I'd gone back to school to get my additional degree as an RN. And I didn't finish that until I came back to the Twin Cities. And I started working in one of our major trauma hospitals within the Twin Cities. And did that as an LPN while I was finishing school. And then as I graduated, began working as an RN in that hospital. And quickly rose in the ranks and became routinely working as a charge nurse, and then as a unit shift coordinator, or in charge basically of the unit the entire time or whenever I worked. So by that time I had been a nurse in the field. Gosh, this was the late 1990s, so more than a decade in nursing. And there were increasing pressures, work with less staff, do more, take this additional patient, figure out how to navigate this tenuous situation with patients, not enough staffing, and complex patients that we managed. I worked on a surgical trauma orthopedics floor, and it was an intense area to work. The first thing that I noticed, and I only noticed this retroactively, so this was after in recovery, is that I began to have signs and symptoms of anxiety and depression. I would go home in the evening. I worked an evening shift, so like a 3 to 11:30, and I would finish my shift. I would go home, and I couldn't shut my mind down. For many of us, whether you work days, evenings, 8s or 12s, you often go home and decompress, spend time with your family, eat dinner, whatever it is. I would go home at night, at my midnight, 1 o'clock, and watch TV, have a snack, get ready for bed, and I couldn't shut my mind off. I was worrying or perseverating about things at work and what was I going to do about this situation, or how could I make this better, et cetera, et cetera. And so that was the untold anxiety. And then eventually depression. I started to isolate and not connect as much with other people. I started to have problems sleeping. I couldn't shut my mind off, and I couldn't relax enough to get to sleep. And so, right or wrong, I made a decision. I was not a huge alcohol drinker at that time and didn't start using alcohol. But as a nurse, I had enough medical knowledge, and I had some leftover pain medications in my medicine cabinet from a previous procedure that I had on hand. And I used that to just take the edge off so that I could be able to sleep at night. And that was the beginning of my disease. And I wish I could say that it wasn't just as easy as that. It was just as easy as that. And so it is a very slippery slope. I work in the field of addiction now, and I've never met anybody who ever set out to become addicted to a substance, whether it's drugs or alcohol. What I found after that was that once those medications were gone out of my own medicine cabinet, it was really easy to begin diverting excess medication that was left over at work. And this would be waste medication, and to be able to save that or keep that for my own use. And I would say that happened for a number of months. And I didn't tell anybody because I knew if I did, things were not going to get better. There were going to be issues with work, etc. So I used an isolation, and I continued to pull myself back from everything and anything. We talked about the 4 risk factors. Hopefully you can identify several in the story that I've already identified. And this probably happened for 8 or 9 months before I could see the writing on the wall. I had started to experience withdrawal symptoms, so that when I didn't have medication or wasn't able to take waste medication home, that I would go through active withdrawal, and did not end up using medications from the street, but eventually would have. I know that at some point. And so I am actually going to stop my story here and tell you the rest of the story when we continue, and keep you hanging on till the next time we connect. And I'm going to pass this on to my colleague, Patty, to start her part.
Oops, I was muted. Hi, everybody. New to this stuff. We're going to start out. I'm Patty Kaiser. I'm so happy to be with you. Thank you. We're going to start out with testing your knowledge, number 2. There we go. Okay, what are some examples of barriers to action that you have witnessed or anticipate experiencing in your nursing practice? Select all that apply. I don't want to be a snitch. Somebody else will address the problem. It doesn't matter what I report, as nothing will probably happen about it anyway. I don't want to break the trust of my colleague, and the guilt of getting someone in trouble would be overwhelming for me. It's quite a selection there. And then we'll look at the answers. Yep. I know that as I read them, it was seemingly things that I'm sure went through my head at one time during my 45 years of nursing. Anyway, today I'm going to talk to you about a couple of different topics that are very much a part of the substance use disorder. Shame and examples of shame. If you look at the picture above on the slide, you know, the person's head's down, no eye contact, tense, anxiety. I heard Dina talk about that. I heard Carrie talk about that. Anxiety is very much a driving force. But shame, an example of shame, is an inability to deal with the wreckage of the past. You know, a lot of people get shame and guilt confused. Guilt is how I feel about something I did. Shame is how I feel about who I am. A little bit different. So that inability to deal with the wreckage of the past goes into the core of who you are. Feelings of embarrassment, feeling inadequate, feeling flawed. That is a very deep, deep feeling. And it's very hard to rid yourself of those feelings. And you may not even recognize it at first. You may have felt that your entire life. So shame, also, I know that Dina talked about this too. It's about living in secrecy. Living in secrecy with a substance use disorder happens both active using as well as in recovery. Many nurses don't like to acknowledge that they're in recovery. I have 38 years of continuous sobriety, and I don't know how many people I told about it at the place that I worked. And I worked at a substance use facility or unit. So it's not something you openly share at all times, because the last thing about an example of shame is the fear of other people finding out, or maybe the fear of your boss finding out, and that may be used against you in retaliation, or if there was an error made on the floor. Those kinds of examples of shame, and perhaps you have your own feelings about what substance use disorder feels like on the inside, but examples of shame can be numerous. However, there are ways to decrease shame. One of the most important things is about identifying yourself. So owning who you are, owning your wreckage, making it visible in terms of maybe in therapy or maybe with another colleague, such as in the rooms. So it's really important to know that who you are really, and solidifying that, really becomes a landmark in decreasing that shame. It can overcome the perception of inferiority. And I know Dina talked about this, the education on substance use disorder. It's really important that you understand everything that goes on in substance use disorder. And because you're here tonight, that means you did have an interest in learning more. And I hope that you do find out. And if you have questions, make sure that you type them in our Q&A. We would love to be able to address them. Another way of decreasing shame is finding pride and accomplishment in sobriety. Like I said, I'm not sure how many people knew of my continuous sobriety, but I know for sure that in my core of myself, it was an important part of who I am. And it still is an important part of who I am. And it still brought me to this group that I continue to give to, because I'm a retired nurse now. And that's a good thing. Also, another thing that decreases shame is the support of others. It is so important to have their support, whether it be your counselor, your colleague. The support of others is so important in reducing shame. Next slide, please. Stigma. Stigma is a very difficult thing. What is stigma? Stigma is defined as an attitude, discrimination, or prejudice directed towards an individual or a group. The words and actions and feelings can disrupt, destroy, or dismantle a person or a profession. If you look at that word salad in the slide, those are very, very powerful words. When you read it in there, stigmatized, guilty, disgrace, humiliated. People who have substance use disorder, or are even in a family of substance use disordered people, colleagues, or maybe even your family, it's very difficult to navigate through the stigma. As an employee, it's very difficult sometimes to get help in getting care. You're not sure about your HR department. Are they there to help you, or are they there to help the facility? I know Barb will go into a little more detail about how you access help through your contracts or through the language in the contracts. But hopefully the stigma that's associated with recovery doesn't prevent you from seeking out treatment. Stigma can lead to more fear and more shame. It can lead to more feelings of distrust or disgrace. And it can lead to a great deal of anger or frustrations. I know that when I was working on the substance use unit, oftentimes we heard names that were not conducive to a patient, such as those people, or they're your kind, or those nut jobs. I heard it all, and it was very difficult sometimes to feel that. And if you're a nurse and you're having a difficulty accepting your own substance use, then that stigma that you hear from others might also prevent you from accessing care. Next slide, please. So what is my part in reducing stigma? Well, as Dina had talked about in hers, in reducing the risks around substance use disorder, it's also important to learn about reducing stigma through learning about the disease of substance use disorder. SAMHSA, the Substance Abuse and Mental Health Services Administration, is a great website to go to for learning all kinds of information about signs and symptoms, treatments, what's the best avenue for me to take. It's a very, very good resource for you. It's also important to learn about harm reduction strategies. Reducing stigma is about learning about how you can help someone through this. And overdose prevention. Learn more about the naloxone programs. Reducing stigma it's important to learn about viral infections. In our role as a nurse on the substance use unit, we taught about HIV and AIDS and reducing further harm to yourself by needle programs. Also learning about Hep C, cirrhosis, and suicide prevention. As you know, mental health and substance use go hand in hand. Carrie had talked about that, the anxiety, the depression. So it's so important to learn about how do I reduce that harm to myself. It's hard enough to sober up, but it is more important that you seek out and own the help that you want. So learn about recovery, learn about treatment, learn about AA, Al-Anon, Alateen. There's so many things that you can learn about in terms of what kind of recovery there is out there. And also, finally, it's so important to speak up. It's so important to speak out. And it's so important to share what you have learned. I know that talking about mental health and recovery often can be difficult. It's a tough conversation to have, but being a part of that conversation empowers you, and it can be helpful to somebody else out there. When I was researching for this, I went to a TED Talk by Dr. Carolyn Greer. It's called Shaming the Sick, Substance Use and Stigma. I was amazed about what I learned from her around stigma and what us as healthcare providers need to do in owning our own biases and owning our own fears around speaking up. And so it's so important to get out there and share what you learn and share your successes. Use more can you believe statements, and can you believe that you're in recovery now? I love being a part of people's recovery and sharing that joy. And I hope that this helps you to perhaps be a part of somebody else's life as well. And now that's it for me, and I turn it back to Carrie. Thank you. Oh, wait, before we do that, let's test see how we tested our knowledge. So as you can see, all of them apply. That, the examples of barriers is thinking you don't want to be a snitch, or somebody else will address the problem, kicking the can down the road. or it doesn't matter what I report. I don't want to break the trust of my colleague, and the guilt of getting someone in trouble would be overwhelming. However, it would be overwhelming if not only you help somebody, but you could be a part of their recovery. So that is all for me tonight, and I will turn it back over to Carrie. Thank you.
Thanks, Patty. All right. So before I get started with the rest of my section of story, I just want to encourage any of you who have questions, please put them in the question and answer, and then we will respond to them at the end with any remaining time, whether that's a portion of my story or any of the other presenters as well. So what did I do? I now have some gaining awareness that I have a problem, and I don't know what to do. I do recall feeling ashamed, not knowing where to turn, afraid that if I told anybody what was going on, that I was going to lose my job. I remember hearing how some of my colleagues, especially physicians, who had talked about in patients that we treated with substance use disorder, and the words that they used or the descriptors that they used were not favorable. And so it made me even more ashamed to bring it up and to even think about, how do I get help? And in the end, I decided to connect with a friend because I just didn't know where else to turn. And so I had a colleague that I worked with, and she was no longer on the same unit that I was on, but we worked the same shift. So after I got home one night after work, I called her and I explained what was happening and what I had been doing, and the fact that I had been diverting substances and that I had a problem and I didn't know what to do. And then what she said was, the first thing was, you can't go to work tomorrow. And I said, I know that, but I don't know what else I can do. In the end, I was connected with our employee assistance program at my hospital. And I called them the next morning, and I went and met with a licensed counselor who helped to diagnose me with a substance use disorder, and then connected me with another local hospital, a different hospital than the hospital I currently worked at. And I went into a detox unit. And I was there for 3 days. And when I came into the detox unit, I was alone. I stayed in my room. I didn't connect with anyone. Again, I was entirely ashamed of who I was, what I had done, and what had gotten me there. And I slowly came out of my shell during the few days there and connected with some of the other patients and found out that they too had done a lot of things, whether it was in nursing or not, that they were not proud of, and boundaries they had crossed. And it helped me get a little bit more comfortable with that. I was recommended to do outpatient treatment. I was recommended also to connect with HPSP, or Health Professional Services Program of Minnesota, which I'll learn about a little bit about. And so I called them prior to even leaving the detox unit and got connected with them to engage in that program. I started doing outpatient treatment. I was on leave from my hospital at that point, medical leave, on an FMLA leave. And I bet you're all thinking, or at least I was at that point, what are they all saying? What are they all talking about while I'm, trying to take care of myself? I'm guessing they're talking about me. And maybe they were for a little while, but I'm guessing I wasn't the topic of conversation for very long before other things came up. And that's the fortunate thing, is I didn't have a whole lot of time to think about and focus on that. And I wasn't back at work worrying about that. I had to focus on, getting my recovery solid, working on that recovery supports, building monitoring program that kept me following my treatment plan. HPSP is a monitoring program in the state of Minnesota that make sure that you follow all treating recommendations. I was recommended to see a psychologist and to get proper diagnosis. Ended up starting on some medications. I also needed to continue to keep doing all of my outpatient treatment. I was required to go to support meetings. I chose the Narcotics Anonymous or NA fellowship to follow. I got a sponsor, started going to meetings on a regular basis. And part of HPSB was random urine drug screening. So to make sure that I was compliant and abstinent, it's part of the monitoring program. Once I continued to do that for a period of time, I was deemed safe to return to work. And so I had to go back and meet with HR, employee health, my manager, and was needed to have a couple of restrictions in place with HPSB. One was that I not have access to controlled substances for a certain period of time. I think it was about 1,000 working hours, so about half of my schedule. Or half a year, 6 months or so. And so I had to have other people that had knowledge, at least that I was going to have this restriction in place. And I vowed that when I went back, if I had to tell everybody what I had done, that I was not going back, that I would literally quit my job, because I was so afraid and ashamed of who I was and the things that I had done in my disease, that I just felt like I couldn't talk to everybody about it at that point. I couldn't even understand it myself. In the end, I ended up needing to tell 3 or 4 nurses that I worked with that I had a problem with substances. Not any stories about the diversion pieces of it, but that I was going to need help giving medications because I wasn't going to have access to the Pyxis or Omnicell for a period of time. In the end, that ended up being what happened. And at that point, my colleagues were fairly supportive. Not very many of them asked me why I was gone or how they could help, but they did the best they could at that point to support me. And those that I had chose to tell were certainly supportive. And I did well. I stayed sober. This was back in 2001 that I originally went through my treatment. I continued to do the monitoring. Monitoring for me was a 3-year contract. And I continued to go to meetings. I had a sponsor. I saw her at meetings every week. And I continued to have what looked like building a solid recovery. And what I did was continue to do what I had been doing. And what we'll learn in a little bit was that enough? I was just finishing my 3-year monitoring contract with HPSB. I had been compliant with all of the requirements of monitoring. I'd finished all my treatment, and I had maintained my sobriety. And in my next part of the story, we will learn a little bit more about whether I was able to stay in recovery or had other issues that came up along the way. And I'm going to pass off to Barb.
Thanks, Carrie. Good evening. I'm Barb Forshear. I retired from nursing in 2020 in January after 40 years of nursing. Partway through my career, I went to law school and did both careers for a while. I've practiced law for 15 years. About 12 to 13 of those years has just been representing nurses at the Board of Nursing. In my practice, I see nurses at their worst. I see the shame and the defeat that Patty and Carrie have talked about is with nurses when they have an SUD. I joined the board of directors at NPSN to see what I could do to continue to help nurses. So again, I'm talking about the ethical, legal, and regulatory reporting obligations. In this slide, it talks about reporting when you have a suspicion that a colleague has an SUD, is under the influence at work, or is diverting. As nurses, the Board of Nursing is our regulatory agency, and that they are responsible for ensuring that we as nurses practice safely. The mission of the Board of Nursing, for all of you, is to protect the public. It's not to protect the nurse. And this is also the duty of every nurse, to make sure that we're all safe to practice. The Nurse Practice Act is the statute or law that gives the Board of Nursing the authority to act on a nurse's license. The reporting obligation is found in your Nurse Practice Act, and if you've never looked at that, it would be a good idea to read that through someday. The subdivision 1 provides that a nurse has permission to report. It uses the word may report any conduct that the nurse has knowledge of. That may be grounds for discipline, and that will be on another slide. Subdivision 3 provides that the nurse shall report, which is a mandate to report, if you have personal knowledge of conduct that may be grounds for discipline. So while these statutes are somewhat vague, it looks like subdivision 3, personal knowledge, is something that you know, you've witnessed, you have firsthand knowledge, where subdivision 1 is maybe something you've heard about. It could be a rumor or gossip. It's also important to know in the last paragraph on this slide under the HPSP legislation that the reporting obligation under subdivision 3 is fulfilled if you report the nurse to HPSP. A report to HPSP will hopefully allow the nurse to get the help she needs without the board being involved. The board is notified, as I said before, if the nurse has positive screens, relapses, or is discharged for any reason other than successful completion. The board is also notified, however, if the case involves diversion. So the next slide. These are the grounds for discipline, and there's a whole list of these in the Nurse Practice Act. The relevant ones for grounds for an SUD are subdivision 9, and that includes the inability to practice with reasonable skill and safety due to illness, substance use disorder, or any mental or physical condition. Additionally, under subdivision 10, if a nurse is committed through the courts for mental health or substance use disorder, that results in a temporary emergency suspension. And the next slide. This slide, thank you. This slide discusses the nurse's ethical reporting obligations under the ANA Code of Ethics. The ANA Code of Ethics is not a legal mandate, but it does provide ethical context for nurses. So provision 3.6 discusses, again, patient protection and impaired practice. So like the mission of the Board of Nursing, the ANA Code states that nurses must protect the public. Therefore, a nurse has an ethical duty to take action to protect patients. It also speaks to the duty to ensure that the impaired nurse receives assistance. Although that's not likely up to the individual nurse, and the nurse should also be compassionate and caring to the colleague and support the nurse's return to practice. So nurses shouldn't gossip about other nurses. We're there to support them, and that's your ethical duty. The next slide, please. Under provision 6 of the ANA Code of Ethics, this discusses the duty to self, and that's what has been already discussed, that the nurse owes the same duty to self as others. And that's the most prevalent issue that I see in my legal practice is nurses put themselves last. We take care of patients, we take care of the kids, we take care of our parents. We put everyone before ourselves. And what this is really saying is that we need to put ourselves at least around the first position and learn self-care. And there's some tips on this slide for staying healthy, which hopefully prevent a substance use disorder. So now we're going to look at the answers. So the answer to the first one is kind of not actually correct. So nurses who get fired from their jobs are reported to the Board of Nursing if it is a reason under the disciplinary, the reasons for discipline under the board. So if it's a tardiness issue, maybe you're out on long-term disability, or you just can't work because of a physical problem, you're not going to be reported to the board. But otherwise you would be reported for suspension, termination, or resignation in lieu of termination. And nurses do not get reported to HPSB when they're fired from their job. The other one is true that the other two, 1 in 3 nurses who suspect a peer is impaired reported to a supervisor, and that we are obligated under the Code of Ethics and under our Nurse Practice Act, as we saw, to report a colleague who is impaired in the workplace. All right, now we are going to take a quick 5-minute stretch break, so don't leave your computer. And when we return, Carrie will take over with her story. Thank you.
Let me pick up my story where I left off. I was just completing HPSB monitoring, which was a 3-year contract. I was feeling pretty good about myself. I had integrated back to work, was fully in my role as a nurse, as a charge nurse in a major trauma hospital. I had sober support. I had a sponsor, albeit that I saw at meetings. I was abstaining from substances, and I had completed monitoring, meaning I didn't need to continue to have somebody checking quarterly reports 4 times a year. I was not needed to do random urine drug screenings anymore. And for all intents and purposes, it looked like I had achieved long-term recovery. I know now that that was not true. For me, what had happened was I had abstained and had learned what I needed to do, but I had not fully integrated all of the changes that for me were necessary for long-term recovery. And I stayed sober for about another year or so, and then I began to use alcohol occasionally because alcohol was not my drug of choice, and I really didn't feel like I had a problem with that. And I didn't understand the disease of addiction clearly at that point, that for me and for anyone else who has a substance use disorder, what any mood altering substance can do is either allow me to become addicted to that substance, or it can grease the wheels back to my drug of choice. And for me, opioids is my drug of choice. And so I continued to use alcohol occasionally, going out to dinner, having a nice drink. I didn't drink at home. Drinks for me were a frozen margarita with friends out for dinner, et cetera, et cetera. And I felt like I could take it or leave it. And I didn't understand for me that that was a relapse, and that was ended up being a secret. It was not something I shared when I went to meetings. It wasn't something I shared with my sponsor. And for somebody with a substance use disorder or that's in recovery, those kinds of secrets are fuel, at least for me. I began to slowly step back from the volume of meetings. The meeting that I had been going to dissipated. The members went different ways. So I was going to need to find a different meeting. My sponsor and I didn't have as much contact because we were going to the meetings at that meeting. Something that I learned, hindsight for me was important, is we had never worked the 12 steps of recovery. And for me, that was also hindsight a key. And we'll talk a little bit about that. I ended up needing to have surgery a couple of times, a couple years apart into this time frame. And I saw the surgeon. He was very aware of my opioid use disorder and that that was in remission. I did not share that I had begun using alcohol occasionally, and it didn't feel that that was relevant. Again, for somebody like me with the disease of addiction, those are that clue phone ringing. I had this first surgery, came through it successfully, was off on a medical leave from my employer, and then returned when I was well enough to go back to work. I was able to get off of the opioids at fairly short order and returned to work with no issues. And then there was a period of time in between, and then I did end up having a second surgery. And the second surgery was more difficult than the first, and I had some complications following that, which necessitated being on opioids for a bit longer. And During that time, I don't believe I was using alcohol very often, but once that pathway in my brain of somebody who has a use disorder is I've lit up the limbic system, and it's like I've almost pre-prepped that area in my brain. And so, and then I'm using opioids, even though they are medically prescribed, again, for me, is significantly concerning. And about 6 months after I returned from the second surgery, maybe not even that long, I began diverting medications and substances from my place of employment. And it was probably a few months before my employer actually confronted me. And I had a really uncomfortable meeting. I came into work one day. My manager was waiting for me and escorted me down to occupational health, where I met with him, an occupational health nurse, HR, and my labor rep. And they confronted me about the fact that they felt like I was diverting or stealing substances from my place of employment. And prior to that meeting, I had already had concerns about my use, and I didn't know what to do. I didn't know how to ask for help. I was contemplating suicide. I had thought about it, had not identified a plan. And for me, I think the integration of this intervention from my job was my higher power's way of stepping in. I admitted that I had relapsed and that I needed help. And they asked me to call HPSP monitoring from their offices, which I did. And then prior to leaving the meeting, or as I was leaving, the occupational health nurse pulled me aside and recommended that I consider treatment with a certain treating provider in Minnesota. And I didn't understand at that time why or what she was saying. And I was honestly just overwhelmed with everything that had occurred. And so I went home. I called probably 8 or 9 treatment centers and said, tell me about your outcomes. Tell me how that, I can guarantee that I'm going to get what I need to get and get into long-term recovery, because I was afraid, 1, that I wouldn't get long-term recovery, 2, that I would hurt someone else or myself. And I had found the desperation that I feel like I needed to find to be willing to do anything and everything to achieve long-term recovery. And it was a challenge. I ended up making a decision between 2 treatment centers and purely went with the treatment center that the occupational health nurse recommended, because that was one of the 2, and she had made that recommendation and I didn't understand why. What I now know was a godsend for me was that the counselor that I began to work with had been a nurse prior to becoming an addiction counselor. And so she had some inkling of the issues that I might be having under the surface and need to deal with. One of the things I also learned in recovery is that individuals who have a substance use disorder often have to fail once or twice at a lower level of care, meaning an outpatient level of care, to achieve a higher level of care, say a residential level of care. So I was recommended to do outpatient treatment. My job had put me on a suspension from my job at that point, pending an investigation. And so I started my outpatient treatment and connecting with my counselor who had been a nurse. What I did differently in this recovery was I began to talk about all of the things that I would rather or would have rather kept secret. and understand now that they were the fuel that I hadn't dealt with in my first recovery. Much of it, the shame and guilt related to being a nurse and who I thought I was, and all of the morals and boundaries that I had crossed in my active disease, to steal substances, to use substances, to break the law. And those were not representative of who I thought I was. And she helped me unpack some of that and began to slowly identify that for me and for many people with a disease of addiction, when I have an active substance use disorder, I am not making rational decisions. My disease is making the decisions for me. And I have very little say so. My brain will sign off on all kinds of malarkey, for lack of a stronger word, and tell me that things are okay and that I can make anything work and nobody will know, et cetera, et cetera. And that is the why people feel like they can drive and they get in their cars and they drive drunk and they, walk to the liquor store and leave their kids at home alone. And none of those things were things that I did, but they were things that I've seen with individuals with a substance use disorder. And none of them ever intended to do any of those things. And I'm not excusing that behavior. And I had to also come to terms that I needed to navigate any and all consequences that came forward because of the actions that happened when I was under the influence of a substance. While I was in treatment, my job decided to terminate my employment, and rightly so. I had gone through 2 rounds of treatment and had returned to an active use disorder, and they did not feel like they wanted to continue to employ me. What happens with that is that my insurance was also affected, and so I needed to make some determinations, and at that point I determined that I was going to elect COBRA so I could continue my care. And so I did that. I completed my outpatient treatment and started in a continuing care group. For me, the continuing care group was pivotal because it was a specific continuing care group for individuals, and it was specifically women who were healthcare providers. So there were nurses, there were physicians, social workers, et cetera, in that group. And so I got really for the first time to connect with other people that had crossed many morals and boundaries in their disease, that also too would never have made the decisions they made in active use when they are healthy and well. And so we began to be able to process those. I was cleared, and this was my sobriety date is 7/8/9, so July 2008, or excuse me, 2009, July 8th. And I am fortunate to be able to continue to call that my sobriety date, one day at a time. And I, in September of that year, was cleared to return to work and had made some determinations with my sober supports. And at that point, that was my counselor, my continuing care group, 12-step meetings. And for me, that was the Narcotics Anonymous Fellowship. And I had a sponsor, and she wasn't a sponsor in name only. We met regularly. We had begun working the steps together. Again, I went to meetings, and instead of showing up and just talking about the reading or something superficial, I began to talk about the things that ran through my head. Often it would be things about how negative I felt about myself, how low my self-esteem was, how little I thought of myself, how much I would put other people in front of things that I needed or wanted, even at the expense of my own self. And for me, it was so healing to walk into those rooms or into my continuing care group and talk to other people who had some of the same thoughts and were managing and figuring out a way forward and a way up. And it was healing. I, again, wisely sought a job outside of bedside nursing to begin looking for a job. HPSP had also cleared me to return to work in some capacity. Obviously, they were deeming that I wasn't to have any ability to have access to controlled substances at that point. I achieved a job in kind of a case management. Actually, I was a coach for an insurance company, and I did behavioral coaching. And it was helping people make behavior changes around their own unhealthy or less than healthy behaviors, whether it was eating, their weight, blood pressure, diabetes, etc. And I was good at it. I liked it. It was no face-to-face contact. It was phone contact. I had no access to any medications and no direct access to patients. And my job was, I think my hours were like 10 to 6:30. They worked well with my treating regimen that I was still in on that continuing care group, which was once a week. My HPSP monitoring, my supervisor knew that I was in HPSP. And it was a really good recovery job for me. And in December of 2009, I received a letter from the Board of Nursing that said we would like to suspend your license to practice nursing for 18 months. I didn't understand how that came forth because I had done everything that HPSP had required of me at that point. They had not reported me. What I have since learned and understand is that when you are terminated from a place of employment, there is, it's now in legislature, I don't know if it was at that time, that employers are required to notify the Board of Nursing reasons for termination, as well as now it's in legislation that if you have individuals that have or are suspected of diverting substances from a place of employment, that also needs to be reported to the licensing board. And so that was what had happened. And it took that length of time before the Board of Nursing reached out to me. I retained an attorney to help me walk through the process because I was not clear on what needed to happen. And for me, that was a long process. I finished continuing care group in February of that next year. I continued to work, which was allowed while my license was under review with the board. Met with my attorney on a fairly regular basis, followed up on allegations from the licensing board. There was back and forth. We met with them once in person. And what you do is you meet with the disciplinary review panel. And I really struggled as I walked through this process with letting go of control. I wanted to try to figure out how to manage and navigate, items that they needed. How was I going to control the outcome? And I worked with my sober supports and said, I really can't control the outcome. The only thing that I can control is myself. And so I began to use the Serenity Prayer to help control my thoughts of worry that I had about the situation and what might happen if I don't have my nursing license. Am I going to be able to keep my job? So on and so forth. My house, am I going to be paying my bills? And so I used the Serenity Prayer to kind of break the chain of thought for me, and it worked. And by the time we got to very close to the end of the licensing process, I sat in a ante room, which is the room that the licensing board escorts you to when they're trying to make a decision and you're waiting with your attorney, and it has one of those white noise machines. And my attorney turned to me and he said, I've never represented somebody who is at ease or seems at ease with the process as you seem right now. And I said, well, I've learned with the help of many individuals that the only person I control in that room is me. And what they can take from me is my license. I'm not going to allow them to take my serenity. And so that's where I'm at. In the end, the licensing board did take my license for 12 months. What ended up happening is that I ended up losing my license in 2010 around Thanksgiving time, and right after that lost my job. I lost my insurance and struggled to figure out what was next. I had been employed for 13 months or so. My employers were very clearly aware of the process, and so I filed for unemployment and was granted unemployment, which offered me a little bit of grace. I did elect again to carry COBRA for a period of time until I could figure out what I was going to do. Luckily, my continuing care was completed at that point. And what also happens in the state of Minnesota, it's not always the same in every state, is that when you no longer carry an active license in the state, you are not eligible to be monitored by HPSP. And for many, having that ongoing monitoring helps keep somebody on the straight and narrow. What I had determined to do was continue with monitoring regardless of whether they were actually monitoring me. I didn't go and have urine drug screens because I didn't have the capacity and I didn't have the financial capacity to do that. But I kept up with the documentation. I kept getting signatures when I went to meetings. And what I did was file that all away in a folder because I knew that in the licensing reinstatement process 12 months from now, I was going to need to prove how I had stayed sober and what did I do to stay sober. And so I had all of that I began to accumulate, and I kept doing what I needed to do for my recovery. I showed up at meetings. I talked about all of the worries and struggles that I was going through and tried to figure out how to keep putting one foot in front of the other. I now no longer could call myself a nurse. I also had to figure out who I was without being a nurse because I have been a nurse since, the mid-80s, 1980s, that is, in one capacity or another. And it was a significant part of my identity. And so as I continue in the next section, I'll tell you a little bit about what went forward for me in that process. And I'm passing on to Sarah.
Hello, my name is Sarah Simons, and I am currently working in direct patient care in a hospital setting. As we have listened to Carrie's compelling story, we have the opportunity to think about where we might appear in such a story. Are you her coworker? Her patient? Are you a friend? Are you the occupational health nurse? The HR professional? Are you a nurse in recovery? Are you the nurse just going about their business? When we look at this poll question, we can look at some possible responses for a situation where a nurse may be experiencing substance use disorder. It can elicit a lot of responses from us. We might just gossip about this nurse. As Carrie mentioned, she worried about what people might be saying about her. We could confront the nurse. We could seek out a trusted colleague to discuss what you've observed and make a plan. Document the behaviors. Anonymously report the nurse. Ignore the situation. Send an email to your manager. What would you be most likely to do in this situation? This question poses a list of possible responses. We are all familiar with the nursing process. Assess, plan, diagnose, implement, evaluate. I would like to just take a minute to draw your attention to your own intuition, or instinct if you prefer that term. It is part of our assessment skill set as nurses, and it is worth giving it the attention it deserves. I'm sure many of us have stories about times when we just had a feeling about a patient that proved to be important in the care of that patient. When you have a sense that something is off, or there's been a change in behavior, check it out. It isn't easy to be the one to intervene, but it can make all the difference in the life of your colleague. Consider what's been talked about already during this educational opportunity. We heard from Patty about stigma and about becoming aware of what treatment programs are available. We heard from Barb about all the ramifications that can come from board involvement, and we also heard even more descriptively and convincingly about our own ethical responsibility for one another as nurses. The idea that when there's something going on in the life of another nurse, something like substance use disorder, that we deal with them with compassion and with grace, that we don't rush to judgment, but that we take a position of support for their benefit and for the profession, for patient safety, for the nurse who's experiencing substance use disorder, the whole spectrum of players, just like we talked about at the beginning of the previous slide about where are you in this story, and how can you be the one to intervene. And depending on relationships that we have with the nurse in question, different roles might play different pieces of this. For instance, this occupational health nurse that Carrie talked about, there may be somebody else that can take the position of an advocate, a union representative, for example, or the nurse manager, or another nurse who's in recovery might have a better lay of the land for what to expect next and what steps can be taken to preserve and protect and promote the well-being of the nurse experiencing substance use disorder. All of the responses here, document the behaviors observed, talk to the nurse, seek out a trusted colleague, all of these are valuable possibilities for how to step in, how to make yourself available in a position of support for that one nurse. For that one nurse experiencing substance use disorder, there are 9 of us who are allies or potential allies to that person. And for that person to journey alone is unnecessary and tragic. As nurse colleagues, we can do better, and we can come alongside to help one another through this experience and other challenges that come in the nursing profession. So as I said, all of the answers are reasonable answers, with the exception of gossip or ignoring. Confronting a nurse may sound aggressive, but talking directly to a nurse with the intent to offer resources and support is not off the table, especially if you, having attended this education and self-educated yourself with other resources related to substance use disorder, some of which are on the Nurse Peer Support website or SAMHSA, many other places to find good resources for treatment options and how to be an ally. But if you have a strong relationship with that person, that's an opportunity for you to speak into their life and to bring relief to a distressing situation. As we interact with our colleagues, we often share resources about any number of things, so why should this be any different? One exception I will mention is that in the event that the nurse is visibly impaired, it is essential that you make arrangements for any patient care responsibilities to be relieved of the nurse, and that the nurse is not allowed to drive for their own protection. It's important to talk to the supervisor in your area and to have corroborating folks that can help support that position. It's uncomfortable, but it's necessary. Now let's go back to Carrie, and we have a spoiler alert that we have a happy ending.
Now we're going to finish the story, or at least that part of my story. And I had lost my job. I had lost my license to practice nursing, and I had lost a job that was really supportive and worked well with recovery. I had no contact actually with patients. I had no direct contact with any medications. And really, I was almost a year and a half into recovery when I lost my my license. I had not understood how much of my identity was wrapped up in what I do. And somebody had wisely once told me that, I don't know, how's the saying go, that if I can no longer do what I've always done, who would I be? And that's what I had to figure out. Who was I without being a nurse? What was I going to do? As I said in the previous slide, that I had been at my job long enough to receive unemployment, although my employer did fight that. So I had to supply some information to the unemployment offices on documentation of that my employer had clearly understood that I had been engaged in HPSB monitoring. I was able to show them my most recent annual review, which was excellent. So that was granted, and that offered me a little bit of grace. What most people may or may not understand is that unemployment is about 60% of what you bring in. And so it allowed me to be able to pay my bills minimally, which was the saving grace. I then had to figure out who I was without that nursing degree, without that job, without that license. And I did that with the supports that I had built. I kept going to meetings. I kept talking about the things that most of us would rather not talk about, and began to figure out what was next. I couldn't apply for half the jobs that are out there that I was qualified for because I didn't have an active nursing license. I couldn't call myself a nurse. And I honestly, I was humiliated. And these were all consequences of my disease, of the active disease of addiction. And I began to walk forward with support in crossing what might be next. I just kept putting one foot in front of the other. Everybody in my recovery community said that this would all figure itself out as long as I kept walking forward. And so that's what I did. Honestly, there were times where I didn't know how I was going to be able to pay my mortgage. I think my water heater broke. In the end, my sponsor's husband actually helped. I bought the water heater and he helped get it installed. And it was a community effort. I applied for jobs, often wouldn't get a call back. I then began to try to figure out what I was going to do next. And I decided that I wanted to continue learning a little bit about possibly being a counselor myself. I thought, I wonder if I could do this. And I reflected back to being in my groups with my counselor who had been a nurse prior to being a counselor, and had a singular thought, I wonder if I could do this. And so I decided to enroll in college and return to school. My sponsor wisely told me that all I was required to do was the effort and the outcome would figure itself out. And so I went back to school. I went to Metro State in St. Paul. I started taking a couple classes at a time. And I also got a job for a school district, and my job was working with kids that were in outpatient treatment. And when adolescents are receiving outpatient treatment, there's a school component that they must comply with. And so my job was helping make sure that those individuals got the school component, kind of escorting them back and forth to the school, as well as contact with their parents. And it was so successful the first year that another adjacent treatment center in the nearby community ended up busing their kids to the alternative school, and I had 2 sets of individuals. So I worked there a couple years. In between, I continued to get all of the HPSP monitoring forms filled out by my providers. I got signatures at meetings and continued to march forward as if I was in monitoring, minus the random urine drug screens. And I had very little contact with individuals that I had worked with from my prior jobs. They had distanced me from me. I had distanced from them out of humiliation and not wanting to talk about what had the humiliation and shame I felt. And I felt that that would just be brought up. It isn't the same when somebody goes out with the disease of addiction as it is with you have colleagues that have, say, a diagnosis of cancer. You know, nobody's bringing, you know, items to your house. Nobody's making you meals. And it's different. And it felt different. It felt different on my side, and I'm sure it felt different for my colleagues. I did have some contact with people that I had worked with at my job where I had been doing case management, and still today have some contact with some individuals that I met through that job. I made new friends and colleagues at the school district and worked there again for a couple of years while I was going to school. In between, my 12 months had been completed with my license, and I determined that I was going to go back to the licensing and apply for reinstatement. And it is a process. There are several steps that you have to do before you can even meet with them, and then it's a scheduling of a meeting. And again, it's a really uncomfortable meeting with them, and you really have to talk about what you've done for your recovery, how you plan to stay sober if you begin to work as a nurse, what your hopes are for types of work. And in the end, the licensing board returned my license in what's called a stayed suspended status, meaning that the license was active and it was still under suspension, but the suspension was stayed, meaning I could actually practice as a nurse and I could call myself a nurse. What ended up happening also is that what has occurred is a matter of public record, and that can make getting a job as a nurse difficult and challenging. And I did apply for jobs. I was not called for interviews. I have to honestly say I didn't try too hard because I was going to school part-time. At that point, I was also interning in my counseling degree, and I was working part-time, so I was really busy. And in the end, I never returned to the practice of active nursing at that time. Although my license was in that status, when my license was returned, I did need to re-engage with HPSB monitoring, and I did that as well. And then I graduated in 2013 with my degree from Metro State as a drug and alcohol counselor, became licensed in the state, and then needed to determine what was I going to do. Was I going to actively pursue a nursing job to complete and get rid of the requirements? So when I got my license back, there were a couple of restrictions on my license. One, I couldn't have access to controlled substances for a certain number of hours, and I couldn't practice in certain disciplines such as home care, etc., where I would be alone. And I determined that if I didn't start working as an addiction counselor somewhere, no one would hire me in that role either because I wouldn't have experience. And so I began seeking employment as a counselor. And it ended up being employed by Hazelden Betty Ford Foundation in Center City, Minnesota. And very shortly after hire, met and worked with Dr. Mark Meyer and was able to work with their healthcare professionals program and became a nursing director of their programs there. And I worked there for about 6.5 years and really had the opportunity to, what I hope was positively affect individuals and nurses and other healthcare providers with the disease of addiction and let them know that they can walk forward and they can hold their heads high, and we can walk through the challenges of achieving and finding long-term recovery and coming out the other side, being able to hold our heads high, understanding that the things that we have done in active addiction are not who we are. They're the things that I will do when my disease is active. They're not decisions that I will make while I'm healthy and well. I resigned from my job from the school and started working for Hazelden Betty Ford. Again, I said I worked there for about 6.5 years. And in between had found connections with individuals in the rooms of 12-step groups finding nurses, medical assistants, providers, etc. in the rooms and having that connection. It was really difficult otherwise to connect with individuals that were working in healthcare. There were no healthcare specific groups. There was no NPSN at that time. And today, NPSN offers that connection for a nurse to another nurse, one day at a time, to be able to connect in meetings, in a one-on-one peer connection, to empathize, to walk through some of the issues that I faced in my recovery and hopefully positively impact lives. And so we do this education to provide that as a resource, and we're always looking for volunteers, whether it's on our education committee, our outreach, our advocacy, or a financial support or donor. And so I thank you.
Hello, my name is Deb Mathias Anderson, and I'm the Executive Director of NPSN. I've been with this organization from close to its beginning, first as a member of the Education Committee and then as a member of the Board of Directors. I learned about NPSN initially as I was exploring work re-entry of nurses with substance use disorder for my doctoral dissertation about a decade ago. I've been involved with NPSN ever since. Peer support in our name means we offer peer support throughout the month, now mostly through online groups. Over this past year, we have served an average of 465 nurses per month with our groups. Most of these participants are Minnesota nurses. Our Tuesday night in the rooms meeting, however, is where we see the most nurses, over 100 per week, who come from mostly Minnesota, but from around the country, and sometimes even from different countries from around the world. These nurses come together in a group led by one of our volunteer NPSN group conveners who is in long-term recovery from substance use disorder. The purpose of our peer support groups is to share and support one another in recovery. We welcome any nurse with a substance use disorder to join our groups at any time. A list of our meetings, both in-person and online groups, can be found on the NPSN website. Included are instructions, and I'll link to or find these meetings. There are other ways to volunteer with NPSN. One way is donating your time by joining one of our committees who help keep us going. The committees meet just once per month for about an hour. Our two most active committees are the Education Committee, who have presented the CEU event, and the Outreach Committee. If you're interested in joining one of the committees, please send an email with your interest to the NPSN email address. NPSN is funded totally by donations, so donating money is another way to contribute to our mission and to help fund presentations such as this one. See our website for ways to donate. And lastly, NPSN has a speakers bureau with participants and speakers who are happy to make presentations about SUD among nurses. If you belong to other nursing organizations or are involved in an academic nursing school setting, we are always happy to talk about this topic to nurses, nursing students, and healthcare providers in a variety of settings. If you have questions or comments about this presentation, we welcome you to contact us by way of our email address. If you have ideas for other presentations that pertain to the issue of substance use disorder among nurses, we welcome those ideas as well. I conclude our presentation with a core NPSN belief. We believe that every nurse deserves access to treatment, help in preserving his or her nursing license and employment status, and ongoing support by peers throughout the recovery process. We know we make a difference in the lives and careers of nurses who join us, as the quote on this slide indicates. Thank you for participating in this presentation, and we would love to hear from you. Thanks.